Greetings, ladies and gentlemen. My name is Abdoulaye Djimde from the University of Science and Technology in Bamako. I'm co-chairing this symposium with Jaishree Raman from Johannesburg in South Africa. Welcome all of you to this Side Symposium on ways and means and ideas and on how we can discuss better ways of engaging the policymakers in the field of genomics and molecular surveillance, malaria molecular surveillance. We have lined up a number of colleagues that are going to kickstart the discussions. We've presenting two scientific presentations and two policy type of presentations are going to be made, and this will be an opportunity to really engage a discussion on how we can build a bridge between the geneticists, the research community, and the disease control, the National Malaria Control Programs, and the Ministry of Health colleagues dealing with policy making in the malaria field. So the first presentation is going to be done by Professor Daouda Ndiaya from University of Cheikh Anta Diop in Dakar in Senegal. Daouda, you have the floor.
Thank you, Abdoulaye. Thank you, everyone. So thank you for the invitation. Yes, as you mentioned, I'm going to discuss about how the genomics data has been integrated to the Senegal National Malaria Control Program system to make decision for real-time intervention and as control as for elimination. Next slide, please. So as you can see here, Senegal have been doing a lot of effort since more than 20 years, 2 decades now, to really control the malaria. And from 2000 to 2020, the incidence malaria prevalence and mortality and morbidity drops a lot drastically from 35% to less than 4% for both morbidity and mortality. And this effort was been because of many intervention. And all the intervention you see in here, from IPTP to SMC through ICT testing, have been implemented using, finding from UCAD and other partner scientific research activities. So in order to implement that, and then I come later, how this has been built. But again, all the intervention put in here are put before and prior to research activity. Next slide, please. Next slide, please. Yes, and I mentioned that Senegal dropped that, sorry, previous slides. Previous slide, please. I was saying that Senegal prevalence will drop down drastically. Now we are going to pre-elimination nationwide, because in the north we have pre-elimination. But as you can see here, there is two parts here in Senegal. We have in the north the pre-elimination, where malaria almost not existing, where even using those tools, malaria diagnosis become maybe not the right tool. And a lot of question is coming from the health facility, where those patients they are seeing in the region are coming from. Are there, if they are imported, or also local transmission, indigenous cases. And in the red side in the south, malaria is still a burden. So for all of that, NMCP is asking question. And as you can see, all the interventions are the same in the nationwide. But why in the north we have been seeing green for elimination, and in the south we have been seeing also red. So the question has been read. And next slide, please. As I can say, so, and they come back to us for many years now and see how a tool like genomic tools can help, because they're using a lot of intervention and indicator. But within the 7 past years, they've been tackling on seeing exactly if those interventions are successful or no, because maybe they're looking for the end parasite, and maybe those intervention or indicator might be not working a lot. And understanding that we have been working with Harvard University and abroad for many years with Gates Foundation support, and we working also to provide them in real-time data for genomics and always publishing data. They come and see how we can use the genomic for surveillance. Next slide, please. Next slide, please. Next slide, please. Hello?
Actually, he is 3 or 4 slides ahead. So maybe, are you seeing the slides? Daouda, are you seeing this?
Yeah,
slides?
now it's sorry. Yes, now I see it. Sorry. No, previous slide, please.
Yes, please go back a few slides because he was not seeing your slides.
Yes, sorry. And as I mentioned, you go. So, I mean, next slide, please. Djimde, are you having the same? So before this slide, there is another one that
just before the add value.
Yes, before the add value. So next, you'll go next then. No problem. Go next. Next slide. Okay. Okay. Anyway, so I was mentioning that in the north we have elimination, and in the south high. And next slide, please. Next slide, please.
Yeah.
Okay. Sorry. So yeah. So and the question is in the north. Previous slide, please. Previous slide, please. Can I do the control from here? Can I share my screen? Maybe it's okay. So yes, please stay here just for 10 seconds. So and the question was, if in the north where the elimination, if all the cases reported at the health facility are coming from other region, or if they are locally transmission. In the south again, if all the prevalence we seen is a problem of intervention or maybe bordering importation cases. Next, okay. And as we know, at value, what we were looking for is to understand in the north elimination if local transmission continue as is critical as imported or from other things. In the south, high transmission improving in access to and quality of case management have resulted to a bundling reported incidents. Next slide, please. Next slide, please. I don't know. I think you moving. I don't know what happened. So we okay. To do activities, this job. So with NMCP, we agree to work on all 24 Sentinel sites, where they reporting epidemic in a weekly basis all cases. We have been implemented with them and samples collection for full fever cases, even for some time for those who are positive by microscope and RDT, and those who are false negative. So everything has been collected in a filter paper for genomics investigation. In parallel, also, we're doing community investigation, meaning we have been selecting several sites in the burden site in Tambacounda, Kedugu, in the north in Shatol, in Chess, in Tuba. So many sites, including clinical and communities was done. And we also been working in many years for clinical, for surveys. So next slide, please. Next slides. Okay, very quickly to show you how we're working, why we come to this integration of the genomics data. Because as I said in my previous slide, in any activities implemented, data was being generated. But before that, NMCP and us work and discuss with the community to agree on the implementation to see the feasibility as such activity. And based on the finding, we're sharing all the data, agree to make a protocol, agree to make an intervention before we go to the community for implementation. Next slide, please. So I'm saying time is going. So for that, there are several type of testing we have been using. For many years, I mean, for a decade, we were using the barcoding with 24 SNPs to see the parasite genetic relatives from in Senegal, from different series and from different hotspots, survey and clinical activities. And recently, since 5 years to now, we have been also using the genomic sequencing, all coming from filter paper quality from the field. Since 2006 to now, today, all the Sentinel site and activity and clinical site for the NMCP has been target for sequencing and genomics activities. Next slide, please. And as you can see here, everything comes from CHESS, because CHESS was our original site where since 2006, 2008, we have been able to really demonstrate that the genomics is a real marker to track parasite in terms of population movement, also in terms of importation, exportation. And coming from that, they agree to now include genomics activity in any activities at the NMCP where they are struggling with impacting, having to measure correctly the impact of the intervention, because as I say to my previous slide, many of the indicators now are not very useful to explain what happened really in the field for the transmission and also for others like drug resistance and surveillance. Next slide. And the biggest problem for us was in Jurbel in Tuba, because the particularity of Tuba is every year, almost 3 million of people was joining for 10 days as pilgrims for Muslim holiday celebration, and they're coming from everywhere from Senegal and outside Senegal. And in Tuba, which was not in the red area, meaning where the malaria was bigger and burden, but the number of cases was so high, and the reason why maybe was importation, but they need the proof of scientific proof before they making intervention. And next slide, please. Next slide, please. And as you can see here, even this slide as one showing that we have been seeing clonal parasite in Tuba, and many others indicators joined together help us to understand that effectively all those population affected in Tuba are coming from other region. There is a next slide, please. So as I mentioned earlier, and then we see that in Tuba, for instance, here, many parasites come from Senegal, and that's why, as you know, SMC, for instance, was implemented only in the south where the prevalence was high. But due to those importation cases, very important, NMCP agreed since last year to implement SMC based on our findings, because we know that the goal was trying to track and to control those prevalence to be down. That's why, as I mentioned, using the genomics and other indicator finding, we'll be implementing SMC in the south, and addition to other. Next slide, please. And as I say, they say that parasites are coming from everywhere to Tuba. Next slide. And the other problem was importation. Very quickly, the chapter was parted on the green area where transmission was very low. And many report was mentioning that importation was the main cause of malaria. But using genomics, we were able to know that effectively there are importation, but there are also indigenous cases. Reason why the north was not being targeted as intervention, but now since 4 years with MASEPA and others a partner, Rashatol is become in the north as malaria control area where all the intervention are targeted everywhere are also implemented there. Next slide, please. The South as the end for the genomics assisted understanding. Within the genomics, as you can see here, from 2013 to 2019, we see an increase of the monogenomic, meaning whatever that they say, intervention is working greatly because the monogenomic infection is going up in comparison to the polygenomics, meaning in terms of transmission is going down. So intervention that can be implemented are very successful. Reason why those partners were ready to move back from Kédougou, from the south, agreed to continue intervention because they know for sure that genomics help us to understand the transmission is really going down for intervention. Next slide, please. And as Mami will be presenting this maybe in the GEM meeting, but even drug resistance also will be used for monitoring intervention as efficacy of drug. Next slide, please, for over 2 decades. Really, I mean, last month, NMCP, because of UCAT finding, and you hear the national TV, it was a very well, I mean, transmitted. They agree now to implement molecular tools, LAMP tools, in the clinical side for Senegal. I think it's the first time in Africa that we see this kind of intervention in addition to microscopy and RTT. Next slide, please. Next slide, please. Yeah, go ahead, next slide. Yeah, very fast. You can continue slides, please. So what happened is that because we all, for many years, work as a team, NMCP and UCAT did everything in the same, publication was done in combination with them for anything that are finding, because we consider NMCP as part of the UCAT team. That's why they agreed to implement any finding from the UCAT. Next slide, please. Finally, as a main finding, now, as you can see, please, next slide, please. Slide, please. Next slide, please. Yes, as you can see here, now genomics is part, it is the Senegal NMCP data generation. And as you see in black here, that genomics is really part of the data management, and all the findings from the genomics are used in real time for control. Next slides. Next slide, please. And in Senegal, now, in any annual report from 2020 to 18 to now, the genomics findings are put it there and the recommendations are implemented in real time. Next slide. Next slide. Next, please. Next. These are part of the recommendation from the national report. Yeah, so thank you very much for, I think that was the last slide for Recruitment. So sorry for this internet issue. So I hope we catch the main of the point. So thank you very much for that. Sorry for the internet issue.
Thank you, Daouda. And I think there have been some internet issues, so I would keep the questions for Daouda at the final Q&A session. And Jaishree, why don't you take on the chairing of the rest of the session, and we'll move straight to the second talk, which will be Deus Ishengoma's presentation.
Thank you, Djimde, and thanks to the organizers for giving us a chance to briefly share with you what we have been doing over the past year as we rolled out our molecular surveillance of malaria project in Tanzania. This is a project funded by the Gates Foundation. We appreciate their support, and it's being implemented by Tanzanian and our collaborators from the US, from the University of North Carolina, Brown and CDC. So I wish to acknowledge their support as far as we have gone. Next slide. Since we already know that we really need to embrace molecular surveillance for malaria, I will share with you the aims of our project. And so the main aim is to establish local molecular capacity for molecular genotyping, sequencing, as well as analytics and interpretation of data. And we'll do that in 6 specific aims, and 3 of them are scientific, while 3 are supportive. So the first is to generate diversity, genetic diversity and population structure of malaria parasite data, and then looking at drug resistance throughout the country and over time. And the third is to map and monitor HRP2 and HRP3 gene deletion and how they impact the HRP2 rapid diagnostic tests, which are currently being done in Tanzania. And support these aims, we have the training for researchers and students to be able to ensure MMS, which is molecular surveillance of malaria, is sustainable. And again, we have an aim on engaging NMCP. And in Tanzania, NMCP is part of the Ministry of Health, but we do have another ministry which owns all the health facilities in the country. This is the President's Office, Regional Administration, and Local Government. So the two ministries and the other stakeholders are our main collaborators locally, and we work together to implement the project. So we'll be looking at how to effectively engage them to identify and understand the gaps they have and develop use cases where we can apply molecular surveillance. And finally, we wish to develop, and we are working on that actually, a framework and platforms for storage, management, analysis, and sharing genomic data and associated metadata as part of our initiative. And how, the next slide. How are we doing this? We plan to do the first three aims by undertaking genetic studies in Tanzania. And these will focus on M1 and M2, that is parasite populations and drug resistance, and also HIP2 gene deletion. And to do this, we are covering 100 health facilities in the country, distributed all over. I'll show them up later. And in these facilities, we are collecting samples, and I will give some highlights later. And as part of capacity building, we are actually using the counterpart model, where every one of us is paired with a collaborator from the institutions I mentioned. So I'm paired with Jeff and John for leading the project. And all the postdocs and students are also paired with our counterpart to make sure that they have specific mission and activities they will need to implement. And so we also undertaking training to deliver soft skills for research leadership, grantmanship, research management, etc. We are working on stakeholders engagement through meetings, workshops, and other activities, also through joint implementation of the project. And we have an activity where we are developing and testing a model that we think might be useful in the engagement process. And finally, we are developing and we will implement a data access and management plan. Next slide. So to be able to implement our project in partnership with the NMCP and the President's Office, the Minister under the President's Office, we started by developing the proposal together. And once we got funded, then we started the discussions on how to compose the team, recruit staff, set up the lab, which is critical for sustainability and procurement of equipment, and then the recruitment of students. After that, we agreed on the governance of the project, including the terms of references for each committees and other implementing mechanisms. And then we worked together through a meeting we had last November, where we reviewed the aims, deliverables, and study sites. And in this, we actually made sure that we are addressing questions which are critical for NMCP. And through that, we revised and agreed on the project work plan as overall, and particularly for this year. And this included agreement on stakeholders engagement strategy, data safety and access and management plan, training of researchers and students, training of field teams for sample and data collection and sample collection together, as well as planning of laboratory analysis and dissemination of findings. So next slide. We, after that, we set up a team, and as you can see, myself as a PI, Celine, who is the project manager, and Christopher, the finance manager, and other members of the team. But you might be interested to see 3 colleagues from the National Malaria Control Program. Initially in the design, we had 1 liaison officer, LR, but after the discussions, we ended up agreeing to have 3 because of their roles. So Dan is the lab focal, Abdallah is the focal for case management, and this Jenunu, she's the focal for M&A, surveillance monitoring and evaluation. And so our team is almost done. We still have 1 position for a lab scientist because the one who was there has been promoted to a PhD position. Next. We had to go through a very hard process of recruiting postdocs and students, and we now have all the positions filled, 2 postdocs, 3 PhDs, and 2 masters, trying as much as we could to ensure gender balance. Although for postdocs, it was a hard thing to do because we don't get qualified applicants. Next, please. We also made sure our colleagues have everyone we need on board. So Jeff had a postdoc, John a postdoc, and we have Bronwyn, Kumar, and Eric at CDC, and we're expecting to fill 1 position at CDC for a laboratory technologist who will be involved in HIP2 gene deletion analysis. Next, please. So this is the structure of our project. We set up a project advisory committee, which is basically within the Ministry of Health, led by the Chief Medical Officer, who is the 3rd in the rank at the ministry, and co-chaired by NIMRI Director General and the Director of Preventive Services. And the program manager, NMCP, standing behind in this picture is behind the Chief Medical Officer. And then we have representatives from the Directorate of Diagnostic Services at the ministry and 2 universities, medical universities in the country. We have the Joint Implementation Committee where NIMRI, ourselves, and NMCP meet and decide on how we move forward with the implementation. And then the project management team, that is NIMRI and the project kind of internal. And then we have the project implementation team, which encompasses everyone I showed in the picture. And we are guided by the Scientific and Strategic Oversight Committee with experts from within and outside. And we have Chaki from Ifakara, Prof. Mbaga from Kesarai in Kilimanjaro, Isabel Chor. We have not contacted them. So some of them might be seeing their names for the first time. So we'll be contacting them because they have been approved by the Project Advisory Committee. We have Carol, who will be the chair, Prof. Barry, Elizabeth from Deakin, Australia, Jaishree, Dr. Matemba, and Prof. Khalid Bashir. So this is how we are managing the project together. Next, please. We have been doing lots of engagement activities. In the first picture, top left, that's the first meeting we had after several consultations. So this is the first meeting of the Joint Implementation Committee, where NIMRI, NMCP, and the project team sat together to streamline and agree on the implementation of the project. The top right and top bottom are the pictures of the first ever workshop we did with all the stakeholders from the 13 regions in Tanzania, which are involved in the implementation of the project. And top pictures for regional administrative secretaries who are like prime ministers of the regions who attended, and we're happy to have that. And the top right, the bottom left is the first meeting of the Project Advisory Committee, which we had last May. Next. So we embarked from January to collect samples. We did joint training of all the staff.
We only have 3 minutes left.
Yes, the picture at the bottom shows members from NMCP, NIMRI, and the POLR who attended the training in Mwanza. And this is the project team which was there. And we did the assessment and started the collection of samples. And we covered 100 facilities as I showed here, but we are also covering 3 villages where we are collecting asymptomatic samples. Next, please. So as I mentioned, we are covering 100 health facilities in 10 regions, targeting 3,700 samples, and we already collected over 3,600 of them. And we are also covering 30 facilities out of the 100 for extended collections with the aim of collecting over 3,000 samples, and we already surpassed the target. And in the cross-sectional surveys for asymptomatic individuals, we aim to collect 600 of them. We are now finalizing the collection and already had 500. We have 500 of them. These are the pictures during the surveys which are ongoing. Next, please. So we have gathered lots of experience working together. We had delays engaging NMCP, but it finally worked. We are encountering problems with the procurement of equipment and reagents. These are common in most of the sites in Africa, but we are working on that. We have had lots of problems with the recruitment of students and staff, which we sorted out. We are now facing problems with the universities where our students can be effectively trained and supervised, and then data and sample quality issues, as well as sharing of the materials. But we also have internet challenges, as you saw from Daouda, and that's something we really need to sort out. Next, please, and that should be my final slide. So we managed, despite the COVID pandemic, to launch the project with the support of NMCPs, and we're now doing well, although some of the milestones, particularly innovation of the lab and procurement of equipment have not been completed. Our plans for next month have been well organized now. We'll be moving to analyzing the samples in the US and then preparing the reports for dissemination and planning the next round of collection. Next slide. So I wish to thank all the support we had from all the collaborators and stakeholders. So thank you so much for listening.
Okay. Jaishree, are you able to take over? I see that
Thank you very much for a very interesting talk. Yes, I am. Can you hear me?
Yes, please go ahead.
Yes, we can.
Perfect. Yeah, thank you very much. That was a very, very interesting talk, and I think we don't have any time, so I'll keep your questions to the next session, till the end of the session. And I'm just going to hand over to the next speaker, which will be Professor William Yavo from Côte d'Ivoire, to tell us what's happening in Côte d'Ivoire. Professor Yavo, are you online?
So it's the IT need to put his slides up. Yes. William, are you there?
Oh dear, I don't know if we've lost William.
Oh.
Are you there?
I don't see William. So
if not, we can go to me.
Yes, I'm here, but I have some problem to open the video.
So we can hear you now.
I need the permission from the.
So just go ahead without the video.
Yeah.
Do you see? Okay. Do you see the slide?
Yeah.
Just go ahead without the video.
Yeah. Okay. Okay. Thank you very much. First of all, I want to thank the organizer of this workshop, this symposium, and today I'm pleased to talk to you about the use of malaria molecular markers for decision making and the current status and challenge from Côte d'Ivoire. Next slide. So as you can see on the map of Africa, Côte d'Ivoire is located in the west of Africa, and we share the frontiers with countries like Mali, Burkina Faso, Ghana, and Liberia. And we are not so big as Mali because our area is less than 400,000 square kilometers, and the population is around 24 million. In Côte d'Ivoire, malaria incidence is more than 150 per 1,000 in the general population, and the malaria death cases is around 1,300 cases. This data are provided by the NMCP in the report of 2020. Next slide. So the situation of malaria transmission is not the same in the different region of the country, as you can see in this map. And but generally the transmission is permanent with peaks during the rainy season, and the most prevalent parasite is P. falciparum, and concerning the vector, the main vector is Anopheles gambiae. Next slide. For malaria policy activities here in Côte d'Ivoire, the NMCP is supported by a group which is called a Scientific Advisory Group. Is a group of independent experts from different research centers. So they orient and review the NMCP strategic plan. They define also the different area of research, and they support advocacy for malaria control and elimination. And for anti-malaria drug resistance surveillance studies, we conduct different kind of study, and we have the therapeutic efficacy study, mainly with ASAC and AL, each 2 years following the WHO protocol. We have also some molecular tests, and sometimes we conduct sensitivity ex vivo study. Next slide. So, and for the efficacy study of anti-malaria drug, we have 12 sentinel sites in the country, in the west, in the south, in the center, and the north. So because we have different kind of facies, epidemiological facies of malaria in the country. Next slide. And from the therapeutic efficacy study, we collect samples for molecular tests, DBS sample, and also we collected whole blood sample in tubes. And we collect sample also from malaria epidemiology study. And during the TS study, we did some molecular tests in order to distinguish reinfection from recrudescence by using MSP1 and MSP2. And following this study, we can define the rate of adequate clinical parasite treatment success. And for example, for ASAC and AL, it's more than 95%. So, and we have some research projects to know the rate of some molecular markers. And the main project is on PFMDA1 and CRT or Q13. Next slide. So, and this study for molecular marker are done mainly in 2 platforms. Our lab, which is based in the Centre de Recherche et de Lutte contre le Paludisme, the Malaria Research and Control Center in the National Institute of Public Health, and the second molecular biology platform for malaria molecular test is based in Institut Pasteur. We have also different collaboration with different organizations like Pathogen Diversity Network Africa, leading by Prof. Djimde, and Malaria Gem, also a DELGEM1 program, which is a training program for MSCs, PhD, and aspiring leader students. And we have also collaboration with the African Association of Anti-Malaria Drug Resistance. Next slide. Here I want to show you an example of the study in the different Sentinel sites where we have collected some DBS. And so after DNA extraction, we perform PCR tests. And for CRT, for example, we perform PCR RFLP test in order to know the rate of CRT 7060 LL, and also we perform nested PCR for MDA1 and Q13, and we send the PCR project for sequencing, and we did bioinformatic analysis. So for CRT and Q13, for example, we have collected 700 sample, and for MDA1 we have collected 341 sample. Next slide. So after the different tests, we noticed that there is a decrease of the rate of CRT 7060 allele compared to the previous study, because 10 years ago, we have a rate more than 50%. So, and there is a decrease of this rate because we moved for the ACT as a treatment for malaria. So the ACT replaced the chloroquine, which was the first line treatment. And concerning the MDA1, we have an increase of the rate of the wild type allele in position 86, and with an increase of the mutant type in the position 184. Next slide. And here you can see the results about the Q13 propeller allelic polymorphism, and very few cases of mutant, I mean non-synonymous mutation, but the most prevalent is the mutation in the position of 578 as previously described in Africa. Next slide. So based on this different study, we share this study with the NMCPs, and the NMCP defined a new guideline for malaria treatment in Côte d'Ivoire. And for uncomplicated malaria, for example, the first line is AZEC, AL, and DHA piperacin. And for complicated malaria, the first line is artesunate, and following by artemether quinine. And we try to convince the NMCPs of concerning the use of molecular marker in order to have an early detection of anti-malaria drug resistant strain. And then we because it's very important to look for this resistant strain, particularly for artemisinin derivatives and the partner drugs separately. Next slide. So what can be considered as a challenge? The first challenge is to build a national malaria molecular surveillance network, because as you you see we have only 2 platforms, and the study is based mainly on a research projects, and we mapping the marker only for I mean the drug resistance marker only for 3 or 4 sites, and so it's very important to conduct studies in all the sentinel style, and which is one of the advocacy of the advisory group of NMCP in order to raise funds from global funds and PMI, and in order to have a national database to analyze spatial temporal evolution of molecular markers like MDR1 and K13 to adapt strategy. The second challenge is also to standardize the different methods, so to develop SOPs and share the SOPs for all the platform to follow the SOPs concerning the sample collection and tests. And also, we need to improve quality control. Indeed, for us, we have we are in the quality control of WHO, but I think that we need to improve this quality control for all the labs. Next slide. The other challenge is also to expand collaboration for lab equipment.
Sorry, you're at the end of your time, so please try to.
Okay, and so for sequencing platform training in genetics bioinformatics, and also to conduct HRP2 trait gene deletion study, because we have here in Cody a few data concerning this kind of deletion, and also the other challenge is to develop training for NMCP staff in the use of genomic data for decision making, and to have a sort of proactive decision for malaria treatment and guidelines. And we still need to combine TS and with MMS in order to validate the new molecular markers candidates and to define the rate leading in treatment further. Next slide. In conclusion, we can say that malaria molecular markers are used in Côte d'Ivoire for anti-malaria drug efficacy tests, and we need to improve platform of laboratories and build a national network for MMS to take proactive decision for and not a reactive decision. It's very important to have a proactive decision for malaria elimination. And finally, we need to develop regional and international collaboration for data sharing and sharing of experience, professional experience of different teams. Thank you very much. Next slide. Thank you.
Thank you very much. Because you've used all your time, I'm going to hold off your question. And well, I'm going to introduce myself. So I'm going to be the next one that's going to speak, and I'm going to just give you a snapshot view of what's happening in South Africa and in Southern, and some challenges that I perceive for Southern Africa. It's going to be a very short, quick talk so that we have more time to discuss after Prof. Djimde's talk. So if we can just start with my presentation. And if we can move, I'm not going to put my video on because I'm currently in the field and my bandwidth is really low. So if we can just go to the next slide, please. So the next slide is just for those that just don't know where South Africa is and the malaria distribution in South Africa, is that malaria is not endemic to the entire country. It's really just different. Next slide, please. And I'm going to give you a snapshot over a 20-year period, so you can see how the burden has varied considerably. So before 2000, the one province, KwaZulu-Natal, which shares a border with with Mozambique, when you finally see it, is
we've been losing you. The audio.
Can you hear me?
Your audio is coming up and down.
I'm sorry. I'm trying to get to the most stable place that I can.
Okay.
Hopefully that's better.
Yes, go ahead.
Okay, so the blue, which is KwaZulu-Natal, has the most number of cases, as you can see, until 2000. And if you can just press the next slide, please. And in 2001, KwaZulu-Natal became one of the first places out of the Greater Mekong region to add an artesunate-based combination for treatment, because it was discovered that the outbreak in 2000 was mainly due to sulfadoxin pyrimethrin parasites in circulation, together with insecticide-resistant mosquitoes being present in South Africa. And that forced the South African program to reassess itself and realize that the two outbreaks in 1986 and in 2000 were really driven by drug resistance, so that they needed to put in a surveillance program. So South Africa started a drug resistance surveillance program that was part of the NMCP, but was run by its parastatals from 2000. And what they did was they just started monitoring drug resistance markers that they knew that were present. And that allowed us to ensure in 2017 that the outbreak, we could definitely say that was not due to drug resistance, but was due to system health failures. So the drug resistance program that was involved has taken two stages. So next slide, please. So initially after 2000, it was mainly focused on control. So what we used was we just collected positive malaria rapid diagnostic tests from sentinel health facilities across the 3 provinces. We looked at markers that we knew that were available, that were the sulfadoxin, pyrimethrin, and chloroquine resistance. It didn't have any patient information, but we could map it down to province, so we could know what the resistance markers were present in the provinces. And this also allowed us to provide data to encourage both Mpumalanga and Limpopo to change to artemisinin-based combinations by 2007, based on an increase in resistant markers and gametocide carriage. But then, next slide, please. Once South Africa transitioned to the elimination, at the same time was the confirmation of artemisinin resistance in Southeast Asia. And then we realized that our surveillance had to be more specific and targeted if we wanted it to have any impact. So what we did was we implemented something that was known as smart surveillance for malaria elimination, which was really just an enhanced surveillance mechanism. And this was where we collected rapid diagnostic tests and blood spots from all healthcare facilities in eliminating districts. And they were labeled with specific identifiers, which allowed us to map down to health facilities or to household. To next slide, please. And so what this allowed us was to map down to a household or health facility to figure out where the resistance was, where we weren't getting data, or where there was a challenge. And also what the surveillance has done is it's allowed us to add in more markers. So it's allowed us to add in the HRP2 deletion detection using the same system, as well as in our next malaria season, what we're hoping to do is start adding in doing some molecular marking in terms of genetic barcoding to find out who is contributing the resistance or who is contributing to what burden in these clinics, whether it's imported cases or local cases. So there we've got our rapid diagnostic tests and blood spots labeled with a specific identifier that I've shown you a paper-based notification form, but we also have an app paper form. So this unique identifier goes into the health information system. So the resistant markers also get linked into that. So the malaria control program has direct access to the resistance data. So they also understand where the clinics are underperforming or where there might be a problem. So that's all great in South Africa. So now my next challenge is what's happening in Southern Africa. So next slide, please. And then I always come to these talks and I always am very disappointed because when you hear the WHO speaking, they always say that Africa does the most amount of surveillance for the CALCH13 mutation. And it does look very impressive when you look at the map, which was taken from the WARM database this morning, if the slide ever comes up. Next slide. Well, anyway, what the slide does show you
we've lost you again.
There we go. Next slide, please, as well, is that there's a lot of marking up in West and Central and East Africa, but very little in Southern Africa, which is very concerning. Have I come back again? Sorry. Next slide, please. Which gives you an indication that there's very little marking in Southern Africa. And what was tried to be done was that they established the Elimination 8, which was a combination of 8 countries in Southern Africa. The 4 that are in blue were supposed to be closest to elimination, which is Namibia, Botswana, South Africa, and Eswatini. And the ones in red are the second line, which are further away. But if the first line countries get close to elimination, then they should help the second line countries go. But molecular surveillance of any form has been very, very rarely done in these countries, particularly the elimination 4. And sorry, if you're going to go back again. Okay, so it was very, very rare in the elimination 8 countries. And the challenge is because the malaria control programs don't see the value of a molecular marking because they say the markers are not directly related to treatment outcomes. The programs also don't have the capacity to understand the data. There have been regional hubs, and I'm hoping that with COVID showing the value also hoping that more countries will take up the ability to do molecular surveillance, particularly in Southern Africa, and we can have a more representative idea of what the molecular markers are and what our challenges are. And hopefully that will get us, and then if we go to the next slide, to what the World Health Organization slogan for Malaria Day was actually managing to draw a line against elimination, and that the Elimination 8 could achieve its aim of eliminating malaria by 2025. Thank you very much.
Okay, great. Thank you, Jaishree. Actually, we do have a few minutes to take. There's one question that was sent to you, which is what is the status of MARA, M-A-R-A, in South Africa? Jaishree, are you there?
I am here. Yeah, unfortunately, at the moment, it was pretty good for a while. It hasn't in the last few years there hasn't been much action on that, and I think it's something that we need to start picking up again. It's been something that's been dropped off the radar for the past few years.
Oh, okay, great. I see a hand in Nyanda. Justin, can you type your question in, because technically we can't unmute people from here. So somebody's question, curiosity is how malaria COVID-19 co-infection challenges amid of the pandemic.
So in South Africa, it's been very challenging. As you might be aware, we've had a major outbreak of COVID. So it has impacted us in doing our malaria normal interventions, as well as people presenting at health facilities. So we routine services out. So, and especially now that we're going into our 3rd wave, I think we're probably going to have more challenges.
Okay. The person who tried to speak, can you type your question, or maybe you can type it and we can pick it up at a later stage. So while we're moving towards the general Q&A, we cannot unmute to give the floor to people. So just type your question and then we'll take note of it. I think we'll move on
so
to...
let me introduce you then.
Yeah.
So it's my pleasure to introduce Prof. Djimde, it's going to be a fantastic segue to my talk, which is going to explain how pDNA is trying to engage with malaria control programs in sub-Saharan Africa to uptake molecular surveillance. Over to you, Prof. Djimde.
Thank you very much. I will try to save some time so that we can have more time to discuss. Can you go to the next slide, please? Just as a background, as you all know, with technological advance, there's a load of genetics and genomics data out there, and this has brought the field in the central stage of biology and now into healthcare. But there is little translation into the knowledge, into that genetic knowledge for malaria control and ultimate elimination and eradication. And the other realization is that African scientists, by in general, we lag behind again in terms of genetics and in terms of the use of this big data science. And there is actually a wall, as I have been demonstrated by a number of these previous presentations, a wall between the disease control community, the malaria disease community, control community, and the geneticists. Next slide. So to address this, to try to break down this wall, a number of colleagues, African scientists, during a GEM meeting, actually, a few years back, came together to form this consortium that we initially called Plasmodium Diversity Network Africa, pDNA. And as you can see, it includes scientists and field sites from west to east and southern to central and francophone, anglophone, lusophone. We try to encompass the diversity of malaria across the continent. Next slide. So we self-assigned a mission of using knowledge from malaria parasite genetic diversity to inform malaria elimination policies in sub-Saharan Africa. Next slide. And next slide. We started by having a few meetings and to lay the ground of what we wanted to do as a network, and which included doing science and providing genetics data and publishing papers on focusing on the genetic diversity of the malaria parasite, but also slowly going towards including the mosquito diversity as well as human diversity, and lumping all together to see how this impacts on disease. To address the gap of human capacity and infrastructure capacity, we are setting up the hardware in a number of places around the pDNA sites, building laboratory infrastructure as well as training students in genetics and in bioinformatics to be able to deliver the science. Next slide. So the next challenge after delivering the science would be how to get this results to be uptaken by the policymakers, and that is the challenge we have been starting to address through engaging with the National Malaria Control Program community. Next slide. Next. Again. Yeah. So this started as a part of our Belgium program, the bioinformatics training program, where in addition to doing the training of the scientists, we decided to bring 15 staff from national malaria control programs to Mali, and we had a number of classroom lectures in the basics of molecular biology, genetics, and also gave them opportunity to have hands-on training by having them actually run a PCR experiment in the lab, so that they get a feeling of what we are talking about when we present these genetics data. Next slide. Now, moving forward, we realize that one or two workshops are not going to be enough to solve the problem we have at hand, and we are now, next slide, I'm now decided to put together a program that is going to try to address the issue on a larger scale. This is being done in collaboration with the Bill and Melinda Gates Foundation, which we thank here. And the program is called pDNA Genomics Translation for Malaria Elimination in Sub-Saharan Africa. It's a program in gestation that haven't started yet. So the aim is to strengthen the capacity of NMCPs to generate, analyze, understand, and utilize genomics data in their policy making. And we are using a three-phase approach, an exploratory phase where we are going to identify knowledge gaps in training needs of the NMCPs in the field of genomics. And then that will be followed by the intervention phase, in which we will involve a series of training tool development and the delivery of training and the various engagement activities with NMCPs. And then the final phase would be an evaluation to assess the impact, as well as see how this can be sustained. Next slide. So in the first phase, we are going to conduct a knowledge, attitude, and practice exploration of NMCPs in the field of genomics to assess the perception of value of genomics and measure the current level of integration of genomics data in NMCPs, which is expected to be very variable in the various countries. Next slide. Second phase will be developing a protocol and training resources, delivering this training, and using webinars to disseminate the some of the activities and have an opportunity to exchange ideas with the NMCPs, and to do that in the format of both one-on-one engagement as well as group engagement. We are going to have a two-way communication for a creation of opportunity for co-learning between the genomic researchers and the NMCP. Next slide. The third phase will be an evaluation to see how the impact of the intervention has been and whether they are integrating genomics into their plans and activities, and how this can be sustained. Next slide. So the plan is to start doing the fact-finding search in as many countries as possible, and then from that develop the training resources. We will start with a pilot intense intervention, which will be in a small number of countries, 5 to 6 countries, where we will learn and evaluate, refine, improve the strategy. And from there, we plan on expanding and hands-on intervention in initially the pDNA countries in the hands-on interventions, while the webinars will include more countries. And on a later stage, roll out this intervention to a more wider catchment of countries. Next slide. So to translate genomics into knowledge, there are a number of prerequisites. There is a need for genetics and genomics education. For the scientists, we need to build more capacity, have a critical mass of scientists involved in this field, and also with the policymakers and the communities at large. And then build a bridge between both the scientists and the policymakers and the communities. And these engagement activities are trying to address that field. In addition to that, there is the issue of the regulatory landscape and the ethical landscape that need to be cleaned up with all these issues around data sharing, sample sharing, Nagoya protocols, etc. And building the hardware in Africa is another challenge we need to address. having the genomics labs to work. And major challenges in terms of getting the equipment, getting the supplies are not trivial at all. And the engagement has to also be driven towards the international organizations, regional organizations, and NGOs if we are to be successful. Next slide. And pDNA is now turned into pathogen genomic diversity network, where we are expanding the disease catchment as well as expanding the number of countries, but still focusing on how to bring genomics to bear in health in Africa. Next slide. Yeah, I've just finished by thanking all of the partners, and that's it for now. And I think I'm on time. We have now 16 minutes to go into the Q&A session. So I have written down the questions that came in before I start speaking. So I think Daouda had the most questions, and he actually used the chat forum to answer a number of them. So I just re-emphasize some of the questions that Daouda has had. So how did you make the site selection for the genomic data collection in collaboration with NMCP? That's a question for Daouda. Is Daouda around?
I don't think he's still online.
Okay, so we'll move on to the questions for Deus then. So yeah, Deus, thanks for a nice talk. How did you organize the integration of the genomic data with the routine platform of the database of the NMCP?
Thanks for the question. We currently have discussed with NMCP in the data access and management plan, where we have brought in all different stakeholders in Tanzania, including generators of data like those who collect a malaria indicator survey. NMCP is in charge of all the clinical data through the Ministry of Health Information System. And so the plan is to for us to identify all the types of data and then work with the different stakeholders to make the data available for analysis. And then the other path we are taking is to make sure that all the findings we're generating can be uploaded on the DHIS2, Demographic Health and Information System 2, which is a platform where different stakeholders, different NMCP team and the regional implementer, district implementers as well, can go through the dashboard and see the results in their areas of jurisdiction, depending on their access. So we have a good plan of how we are going to integrate the data and make it available to different stakeholders, as well as bring in different types of metadata we need.
Okay, so there's another question that is actually for both you and Daouda, who is now back. So the challenges in procurement and supply chain is a common theme in Africa. Did you incorporate this as you planned the study, and how do you manage the funders' expectations when you don't meet milestones due to these challenges?
Prof, if there are hurdles, this is the biggest one. But again, we are flexible and trying as much as possible to make sure that we get the studies done. For example, when we had problems procuring all the reagents we need for fieldwork through the government system, which is very rigid, we agreed with the NIMRI management and they had to give us cash to be able to procure as part of our field activities, and the field activities have been able to continue. Again, we have retracted some of the stuff from the tendering system and we'll be procuring them from our collaborators. We don't like that kind of approach because we need to build a sustainable system. But at the moment, we think that is the way to go. We are building in like mitigation strategies, and we knew it would be a very high risk to go with. But again, we are sure we will deliver at the same time try as much as possible to build a sustainable system for procurement of reagents and consumables, as well as equipment.
Thank you. Daouda, do you want to add something on challenges with procurement?
Yes, thank you. I think just very quickly, maybe the first question that there's regarding the implementation side. So as I say in my talk, everything has been done in an agreement, in collaboration with NMCP. So in the particular of Senegal, NMCP and WCAT have built one team. So for many years now, we don't have any implementation. For the suppliers, yes, I think Djimde, everyone was distant for many years. So we all are facing the same issue. So getting supplies from overseas to here. And even maintenance of equipment. One of my MySick is broken for just a very little problem. I need to call Illumina to come from EasyIron to come. It takes 2 months, 3 months before they arrive. They will arrive this week after we've been declaring this equipment. It is 3 months now. So it's a problem. The same thing also for the reagent. You can order reagents. I mean, they come, but how long will it take to come? And you can't order many of the reagents for the genomic. You can't store them for 2 years. The expansion date sometimes is very short, 1 year or 2 years. So before you order them, before they put it out the system to sell them and you get them, so you don't have any chance. You order supplies, they came, you have 3 months before they expire. Where the budget is coming from, so how do you deal? So I think this kind of thing need to also, we have support from many leaders. They all know that. I think we need to push harder to make sure that this will be fixed very shortly, maybe.
Yeah, I mean, these are really well taken points, and I particularly like the Deus's comment on finding creative ways of maneuvering the procurement system, which in some of our government institutions can be very heavy, and being able to find ways around that is an example that many people will probably follow.
Yes, Djimde, but that's not sustainable. So we need to find innovative ways to make procurement sustainable. Sustainable for the labs to be efficient in generating the data.
No, I'm not talking about getting it from your partners, but you said NIMRI, you found a system within NIMRI that it makes it easier for you to get your supplies.
It's tricky though. We just have to keep it here.
Yeah. Okay. And Daouda, that's actually, I think as a collectively, this is something the PDNA group had a discussion at the MIM meeting, which is now that we are starting to get a number of equipments on the continent to see how we can talk together, so that if someone comes from Asia to Senegal, the person can actually do preventive maintenance in neighboring countries, and so that it's both good for the person coming as well as for the people in the region, so that the next person don't have to wait 3 months before information shows up. I think we need to talk more to align these
absolutely
aspects. Yeah. So the next question, I think that's all. Yeah, the next question was for Deus again. Somebody was asking you to expand on HLP2/3 deletion.
Prof, I did give a lot of explanation in the chat, and for the interest of the time, I would refer my colleagues there. But suffice to say, we are doing a countrywide surveillance of HLP2 deletion based on WHO protocol, covering 100 health facilities in a minimum allowable by WHO of 10 regions. So I'm happy to discuss further so that we can give more time to other things which have not been answered.
Okay. So Jaishree, did you have any questions that I have missed?
I think there's
actually one that's just come through for you, and they want to know. And it's one that is a challenge on trying to, what's the implications or the challenges of moving from being specifically Plasmodium to pathogens and trying to do it on the whole continent. So what do you see as the positives and the negatives of moving from focusing purely on malaria to going to the pathogens?
Okay, well, the positive is that the issues are pretty much the same, whether it's malaria, translating genetics knowledge from in malaria control or in antimicrobial resistance or any other pathogens that you have. So engaging with, we think that the experience we are gaining and the know-how that we are building for engaging with policymakers in the field of malaria would be easily applicable to actually engaging policymakers in bacterial diseases or antimicrobial resistance or other parasitic diseases. So that's the plus. The challenge is, is a network. The bigger you become, the more difficult it becomes in terms of managing and getting things done right. So that's why we think that we are going to go in with a very phased manner, starting with a small number of countries to actually build the tools and learn from the mistakes that we'll do at a smaller scale. And then once we have something that is scalable, move towards a larger number of countries. Do you have another question there for me? Otherwise, there is a question for Daouda. Yes.
Go for it.
Yeah, go ahead, Djimde.
Are the preventive tools the same for all the study sites?
Repeat, Djimde, please.
So the person is asking whether in Senegal, since you have different prevalence in different places, he is asking whether the preventive tools are the same for all the sites, the study sites.
Okay. Yes, I mean, again, depending to the level of the transmission, as you may know, for example, for SMC, for prevention for SMC, using SMC, you have WHO requirement and recommendation. You can use it everywhere. So anyway, in Senegal, we are of that. So we put it in the area where the transmission is very high, and particularly to the south, and also, as I mentioned, in area where there are a lot of other intervention and NMCP want to clear out of it. But outside of that, for bed nets coverage, I mean, for ACTs used for, I mean, combining testing, treating patients are the same. So there are very few differences generally, but basically, aside of SMC again, most of the intervention and IRS, and IRS and endoreduced spray, they are almost the same across the whole country.
Okay, so there is another question. How can we leverage on data science strategies such as machine learning in increasing utility of the MMS? Also, how do we integrate disparate data sets? Yes. Can you hear me? So this is, I think this is a question for all of us. How can we leverage on data science?
Can you repeat?
How can we leverage on data science strategies such as machine learning in increasing utility of MMS? And also, how do we integrate disparate data sets, including weather, clinical, etc.? So this is for all of us. Can you hear me?
Yes, we did.
Okay, so maybe I will tackle that.
Yes.
I think this is where we, in addition to our network, we need to reach out to other groups that are better versed in these integration of these machine learning and other type of data, including weather, including crops, including rain forecast, etc. So we need to reach out to other groups that are more knowledgeable into these fields so that we can work together and see how this can be integrated. And the other point to make is that there is an important need for developing capacity in data science. We've started doing something in bioinformatics, but data science goes beyond bioinformatics, and we need to train more young scientists on the that can bring all of this together. There are plans to incorporate human host genetics in the GEM program at some stage. That's also a question probably for me. Yeah, the GEM program is an engagement program, and the engagement program is basically trying to increase knowledge of genetics in general. So we start with the parasite genetics using use cases that are close to home, but we will expand to the mosquito and to the human host as we move forward. So I think these are the questions, and we are pretty much out of time. I'm just going to finish by thanking all of the speakers for taking the time in a short notice to really put together these talks, and thank all of the attendees. At some point, we reach 150 attendees, which is, I think, very good as a turnout. And thank the GEM organization for hosting us, and Malaria Jan, Dominic, the Gate Foundation for this opportunity. Thanks to all, and till next time. Bye-bye.